Buenas noches, bienvenidos todos a un webinar más por parte de Íntegra Cancerístico, nuestro último del año. Y hoy estamos conmemorando pues el mes de la concientización del cáncer de pulmón. Vamos a cerrar con broche de oro. Tenemos a dos panelistas, o un moderador y un panelista sumamente importantes en el campo. El doctor Joaquín Barnoya, que ya muchos de ustedes conocen, él es especialista en salud pública con estudios en Nueva York y en Harvard y en la Universidad de San Francisco, y el doctor Jonathan Samet, quien es pulmonólogo y epidemiólogo y es el decano de la Universidad, de la Facultad de Salud Pública de la Universidad de Colorado. Ya dejaré a Joaquín que dé las introducciones o la presentación correspondiente. But Dr. Jonathan Samet, thank you very much for accepting this invitation. We are very honored to have you with us and to share your experience and your knowledge. And please, hopefully sometime very soon we can have you down here in Guatemala physically, in person.
Oh, gracias.
So, thank you very much. I'll leave, lo dejo a Joaquín para que por favor lo pueda presentar como se merece el doctor. Gracias.
Muchas gracias, Eddie. Creo que si aquí se trata de broche de oro, es John el broche y yo solo soy tal vez el pin. Tengo la suerte de haber conocido al doctor Samet, a John, hace tal vez unos 20 años cuando empecé a trabajar en tabaco. Él estaba como director del departamento de epidemiología de Hopkins, y la verdad que el currículum no vale la pena extenderse, no tenemos tiempo, y tampoco John es de los que le gustan ese tipo de formalidades. Brevemente, como ya dijo Eddie, es pulmonólogo y epidemiólogo. Actualmente funge como decano de la Escuela de Salud Publica de Colorado. Se ha enfocado en general en el impacto que tiene los humos inhalados en la salud humana, incluyendo cardiovascular y obviamente pulmonar. Desde el punto de vista personal, les puedo decir que John ha sido los principales impulsores de las leyes de ambientes libres de humo de tabaco, pero también del impacto del tabaco agudo en el sistema cardiovascular. Mucha de la investigación que John hizo ha apoyado las leyes de ambientes libres de humo de tabaco y la salud cardiovascular. Por aparte, ha sido miembro de muchos comités importantes, no solo en Estados Unidos, sino también en la Organización Mundial de la Salud. Es uno de los más dedicados revisores de la revista Tobacco Control y probablemente de los que mejor revisiones hace de epidemiología. Actualmente lidera el grupo de modelaje epidemiológico de la pandemia de COVID en Colorado, y desde 1997 es miembro de la Academia Nacional de Ciencias de Estados Unidos. Jonathan, again, thank you very much. It's quite an honor for us to have you here, and it's all yours. Thank you again.
Bueno, gracias Eddie y Joaquín, y buenas tardes a todos, buenas noches. Una lástima, pero yo creo que yo voy a hablar más o menos en inglés, pero muy despacio, y después podemos hablar en español con preguntas. Entonces voy a comenzar con share screen. ¿Y todo bien, Joaquín?
Perfecto. Perfecto.
Ok, seguimos entonces. Entonces voy a hablar sobre el pasado, el presente y el futuro. Lung cancer, past, present, and future. And, you know, I'm going to cover some very specific topics, but please, when we get to have a conversation, think about everything about lung cancer. I will say now that since I've centered my career in public health, I have not seen lung cancer patients for many years. And over that time, therapy has changed a great deal, and I'll show you some data on its impact on survival. So here's the plan. The past, which is to me very interesting, very important for epidemiology. We learned so much from studying lung cancer. I'll talk about what we learned and how we learned it and how it made a difference. I'm going to talk about where we are now with the ability to prevent lung cancer through, of course, tobacco control, prevent lung cancer through screening, and then ever advancing treatment. And then something on the future, just a reminder about genomics and risk profiling, and then talk about the critical policy choices that we have ahead, particularly for electronic cigarettes and what in the US we call heat not burn products like IQOS. So that's the plan. And we will start with the past. As a reminder, the tobacco plant, the wild tobacco, Nicotiana rustica, and the cultivated tobacco, they were in the New World. So when Columbus made his first voyage, he found the people who lived here using tobacco for different purposes, including as part of religious life. Tobacco, of course, contains nicotine, and the tobacco plant was soon taken all over the world, and quickly people were using tobacco products all over the world after this voyages of Columbus and, of course, others to the United States. Now, a cigarette is unfortunately a perfect way to cause disease. And this is the structure of a modern cigarette. A cigarette has paper around it. A cigar has a tobacco leaf around it. The cigarette contains about 1 gram of tobacco, and that tobacco is treated with chemicals to affect its burn. And of course, there used to be many flavors in the tobacco. Now the main flavor is menthol. Modern cigarettes have a filter. And perhaps most of the cigarettes sold, I assume, in Guatemala have filters. They also have little holes made in the filter to dilute the smoke, to make it feel lighter. Doesn't make it any safer, but those holes are there. The cigarette burns at a very high temperature, maybe 1,000 degrees centigrade. And as it burns, it creates chemicals that are burned and reburned as they settle out. And thousands of compounds are in tobacco smoke. You know many of them, like carbon monoxide or benzene, 70 or 80 different proven carcinogens. So not surprisingly, the cigarette causes many different diseases. Typically, a cigarette burns for about 10 minutes, and the smoker might take 10 or 12 or more puffs. And if they do that 20 times a day, they have more than 200 puffs of tobacco smoke coming into their lungs and causing disease. Now, how did we learn about this problem? This is last century coming into this century. This is number of cigarettes consumed per year by adults in the United States, smokers and non-smokers. So at the peak, people were using, adults, 4,000 cigarettes a year. That's 200 packs a year, averaged across, including both smokers and non-smokers. So the typical smoker in those days smoked 20 or more cigarettes a day. And when I started in pulmonary medicine, I often saw patients who were smoking 40 or 60 cigarettes a day, 2 or 3 packs per day. So what happened? Lung cancer began, and here, going back to about 1930 in the United States, is the mortality rate for lung cancer in men, going up, up, up. That could now be the curve for COVID-19. And this went so high so fast that people asked, what is happening? Why is lung cancer increasing so fast? So there were 2 possibilities considered strongly at the time. These are 2 famous epidemiologists who Joaquin knows, Sir Austin Bradford Hill and Sir Richard Dahl. You may want to know that Bradford Hill did probably the first clinical trial, which was streptomycin as a treatment for tuberculosis. But in their first paper, they said there were 2 hypotheses about the rise of lung cancer. One, that it was worsening air pollution, and the second, that it was tobacco smoking. So there was not clarity. Air pollution had become worse, and smoking at that time was very common in the countries like the United States or England. About the majority of men were smokers. So it was very, very common, and people were not thinking that it could be dangerous. But what happened? Epidemiological studies were done, and here's a few of them. These were case control studies. So very simple studies, finding people with lung cancer, finding similar people without lung cancer, the controls, and basically making a comparison of the smoking history of the cases with lung cancer and the control people without lung cancer. And in 1950, there were 6 of these studies published, and 3 came first that are quite famous for their impact. And they were very clear that smoking was very tightly linked to lung cancer. These studies were simple, as I said. This second study here, the first author, Winder, was actually a medical student when he did his study, interviewing cases of the surgeon Graham, who was the first person to remove a lung for lung cancer, to treat lung cancer, a pneumonectomy. So that's 1950, very clear. And then the next few years, more findings came along that pointed to smoking as a cause. One was some studies putting cigarette tar, the stuff that's collected on a filter from cigarette smoke, onto mice, and showing that a cancer was produced here. The other was that studies were done that were prospective in design. So large groups of people were enrolled into a study. Their smoking history was documented, and then they were followed to see the rate of lung cancer in the smokers and make a comparison to the rate of lung cancer in the non-smokers. And this is the kind of data that came along. This is now risk of dying altogether. Cigarette smokers at the top, never smokers at the bottom, and you can see the much higher rates of death in over time comparing smokers to non-smokers. Even the early studies showed about a 70% increase in risk of dying for smokers compared to non-smokers. And then Dahl and Hill did a famous study of British doctors. They followed 33,000 British doctors for 50 years and tracked deaths from lung cancer, heart disease, other problems in the smokers compared to the non-smokers, a very important study. And Dahl, who I mentioned before, was there at the start, and he wrote the paper at the 50th anniversary findings, which was published. This one's in 1954. 50 years later, he published the 50-year follow-up study. So these studies were very clear in showing that smoking was linked to lung cancer. This is observed to expected deaths from lung cancer by amount smoked. And you can see how the risk goes up with the amount smoked. So where did this go? So the evidence kept getting greater. The problem of lung cancer kept getting worse. And in 1962 in the United Kingdom and in 1964 in the United States, there were major reports that said that smoking causes lung cancer. This is the US in 1964. Our chief doctor, the Surgeon General, a man named Luther Terry, holding the report in his hands, the group of scientists who work on the report behind him here, and then the team that put the report together. These reports continue. I started writing them in 1984, and in 2014, I put together the 50th anniversary report of the Surgeon General, which was over 1,000 pages because we knew so much at that point. And certainly by then we knew that smoking caused lung cancer in men and also in women. So there we have proof, and the proof was so strong. So this now shows the risk of lung cancer in people who are currently smoking by number of cigarettes smoked and making a comparison between the line, each line is from an epidemiological study. There's 70 lines here. And what you want to see is that all the lines go up, some bounce around a little, perhaps because the study's small, but all of them show this dose-response relationship. And some of the relative risks are very, very, very high, 30-fold increase, 40-fold increase. These are extraordinary risks for developing lung cancer. And then what happens if you stop? Of course, that risk drops. So this is now from some studies that had information on how the risks dropped after people stop smoking. And again, you can see the risk goes down. It never gets back for lung cancer to the risk of people who never smoked. So the more people smoke, the worse. Very, very high relative risks. For comparison, say having hypertension roughly doubles the risk of having a heart attack. So here's 80, 40, 30-fold increases in risk. I put this together quite some years ago for a trial against the tobacco industry, I guess una demanda contra la industria, to show how strong a cause of lung cancer cigarette smoking is. And this worked, fortunately. Now, one other important part of the lung cancer smoking story is passive smoking, which has made such a difference in the world. The first study, important study on passive smoking and lung cancer, was published 40 years ago by a Japanese epidemiologist, Dr. Hirayama. And here are his data. He was following a large group of people, and he looked at the rate of lung cancer in women who did not smoke and who were married to non-smokers. That's the blue. In non-smoking women who were married to husbands who did smoke, that's this big block of orange. And then finally in women who did smoke. So the important finding here is that this orange, the rate, is about 60, 70% higher in women married to smokers compared to women who were married to non-smokers. So this was published in 1981, and it was the first of these studies. And as Joaquin knows, the tobacco industry attacked this and many studies that followed, trying to say that these findings were the result of bias. They were so scared of the findings because of the implications for making workplaces smoke-free, for example. So in 1986, there were several reports. I think most importantly, a report from the US Surgeon General, Dr. Koop. I had the privilege of working with Dr. Koop on this report. These are the epidemiological data we had available at the time from the different studies of smoking and passive smoking and lung cancer. And here is the report that we released in 1986. And most importantly, this conclusion that involuntary smoking, passive smoking, is a cause of disease, including lung cancer in healthy non-smokers. So that was 1986. The report also says that separating smokers and non-smokers in the same room, airspace, does not protect the non-smokers. So we didn't say that smoking should be banned indoors, but that was the implication. So the science here was really important. I can tell you that only a year later in 1987, I spoke to the US Congress about having a smoking ban in airplanes. And people said that was impossible because no one would ever obey. And of course, now there are many people who are younger who have never been on an airplane where people smoked, and they can't imagine that was possible. And those of us who were on airplanes with people smoking know how terrible the air quality was. And of course, there were risks. Now, there are other causes of lung cancer that have been identified over the years. Some of them are occupational, environmental. There's some very specific kinds of chemical exposures. And there's been a lot of work on the genetics of lung cancer with really very few, very strong findings. If we look at what the International Agency for Research on Cancer, WHO, has said about different carcinogens, here are a group, some you know well, like asbestos, radon, that cause lung cancer. So different kinds of mining, different industrial processes, all release compounds that are carcinogenic. One important conclusion is that air pollution is a cause of lung cancer. I took this picture in Delhi, India, perhaps 20 years ago. When I woke up in the morning, this is what the sky looked like. Incredible levels of particles and other pollution. And some years ago, I chaired a group at the International Agency for Research on Cancer that concluded that air pollution is a cause of cancer, and in particular that the particles in air pollution are carcinogenic. So this is our group that worked very hard for 10 days to reach that conclusion based on a lot of scientific evidence. So air pollution, of course, is a problem that has become worse in many parts of the world. One other issue that I still think we have much to learn, lung cancer in never smokers. So in the US, maybe 15% of people who die from lung cancer have never smoked. And then there are questions as to what is the cause. Radon in our homes is one cause, secondhand smoke, work exposures, and air pollution. And there's some very important differences between lung cancers in never smokers and lung cancers in smokers. The lung cancers in never smokers have far fewer mutations than those in smokers, for example. And hopefully we will learn more from molecular studies about mechanisms by which lung cancer occurs in never smokers. So I'm going to move on to the present and talk about where we are with lung cancer. We certainly know the causes of most cases. The global burden is huge, with lung cancer the leading cause of cancer death worldwide. The disease continues to change. Lots going on with therapy, targeted molecular therapy, and screening is now possible, and in some countries it's being done. And then I'll talk, when we look to the future, about harm reduction, electronic cigarettes, and the heat-not-burn products. So just for background, of course, fortunately, smoking is still relatively uncommon in Guatemala. The most recent data we could find was 2015. This pattern of fairly light smoking among men, typically not smoking a large number of cigarettes a day, and very light smoking among women is seen in countries of Central America, some South American countries as well, and in parts of Mexico. And then at least the available data would suggest that the number of lung cancer cases is relatively limited, understanding that you don't really have a systematic data collection process in place. So while in the United States, lung cancer would be at the top in terms of cause of death, in Guatemala, it's relatively infrequent. But looking across the world, as I said, there's a huge burden. This is now for men and women together. The places with the higher rates tend to be parts of Central and Eastern Europe. China has had very high rates, particularly among men. In China, about 55% of men smoke still, but only a few percent of women. And then in the United States, Canada, we've had relatively high rates. You can see the scale. And Mexico, Central America, with relatively low burden of smoking-caused lung cancer. Now, I said there have been changes in smoking and lung cancer. And what this slide shows is from 3 different groups of studies, one back in the 60s, one in the 80s, and one at the start of this century, how lung cancer rates have changed from smoking. And what we've seen is that over time, the risks of smoking, of lung cancer in smokers, have gone up. So cigarettes have not become safer. If anything, they are carrying greater risks than they did before. Some of that may be from the changes in the cigarette that have been made. The one important change in lung cancer over time is that small cell lung cancer and squamous cell lung cancer have gone down, and adenocarcinoma, which originally was less common than squamous, is now the most important type. And we think this is due to changes in the cigarette, the ventilation holes that led people to take deeper breaths, and perhaps change the carcinogens that they were exposed to. And these cancers, of course, tend to be more peripheral than central, which may be one reason that screening proved to be effective. In the United States and in many other high-income countries, fortunately, cigarette smoking has dropped greatly. Here's men in the United States. The number of current smokers back in 65, over 50%, dropping down to under 20%. And in many states in the United States now, smoking rates are 13, 14%, and in some states like California, Utah, even below 10%. So we have fewer active smokers, and we have more who are quitting over time. So fortunately. And of course, the good news is that now lung cancer rates are dropping. And this shows the trends in rates of lung cancer over time going down. This, for example, is white males going down. In women, the rates are starting to go down. So this is good news for the US, and the same is happening elsewhere. We're still seeing plenty of cases. We have 220,000 cases a year, roughly, in the United States. So rates are going down, but case numbers are high. So how do we attack the lung cancer burden? Well, that's easy. Ideally, we control tobacco use as our first step in primary prevention, harm reduction, and then now we have screening. And then, of course, at the end, we treat, and our treatments are improving. So cessation, and tobacco control are critical. This is our 2020 Surgeon General's report, with the obvious conclusions that smoking cessation reduces risk of lung cancer and every other cancer. So that's what we want to do. Now, screening, we have had a long history of trying to develop ways to screen lung cancer. This man, Gino Saccomanno, was a friend. He developed sputum cytology. And there were trials done to see if cytology worked, particularly if combined with X-ray. And those trials done about 30 years ago did not show a benefit. Of course, benefit has now been shown with low-dose spiral CT. Also, there's a lot of work on molecular markers, I'll come back to this, that may allow us to pick up cases early. The important study here was the National Lung Cancer Screening Trial done in the United States that compared doing a low-dose CT with X-ray. And 3 CTs were done, and the data were striking in showing a reduction of mortality, about 20% in those screened here. This is years since the start of the trial. Mortality from lung cancer here, low-dose CT group, here the chest X-ray group, and the difference was quite statistically significant. The group screened on top here, more cancers were picked up, and the protocol, of course, was mostly to operate on these cancers and remove them. So there have been trials since, most recently the European trial and the Nelson trial, and these are, the results are similar. So lung cancer screening has been implemented here for particular groups considered at high risk. It's proved to be difficult for many reasons. A team is needed to do this. Abnormalities found on chest CT have to be diagnosed. Surgery may be needed. And so a program is needed, not simply sending people to get a CT scan. So our centers, our bigger centers now have lung cancer screening programs, clinics, and they deal with the many barriers that have been identified. And don't worry about this, except to notice that there are an awful lot of barriers to getting screening done successfully. And it's clearly expensive and involves patient time, of course, and provider time to communicate. A whole sequence of steps is needed, and a team is needed to make sure this happens. But screening is now approved and covered in the United States. Now, therapy is not what I do, and perhaps Eddie can comment here. I mean, of course, surgery, radiation, and chemotherapy are important, but now we have a whole range of targeted molecular therapies and immunotherapy. When I was in training early on, we had very little to offer to our lung cancer patients unless they were diagnosed very early. And 5-year survival was around 15%. Of course, now we have a variety of new therapies that have come out. In the United States, these therapies are actually advertised on the television because there are so many potential candidates with so many people developing lung cancer. So another question would be, have we made gains? And again, these are more of these therapy examples and treatment algorithms. Here is data from the United States. This is now just the death rate from lung cancer and the rate of new cases. Both are going down. But the question we need to ask is, are we doing better with survival? So this is 5-year survival from lung cancer, and we have data out to about 2013-14. And you can see that lung cancer survival is improving and projected to continue to improve. So this is good news. And again, here is now survival by 5-year survival by stage, local, regional, and then more distant or unstaged. And again, you can see a trend of rising survival by stage. So this is good news. We have made some progress, of course, with all our therapeutics. And hopefully with screening, we'll be picking up cases at earlier and earlier stage and better able to treat them. So finally, el futuro. Llegamos. So a couple of things that I think we'll find. So there's an awful lot of work going on with molecular signatures that's very interesting. And I think will provide us insights into mechanisms by which smoking and other agents cause lung cancer. We may find, and as this paper in Science shows, signatures, particular signatures and mutations, some very interesting ones with smoking, more biomarkers, blood biomarkers to try and pick up disease early, proteomics, better understanding of genetics, and no doubt imaging will get better and better. So I think there's a lot to come. I think right now the important part of the story looking at the future is, what is the role of harm reduction going to be? So along the way with lung cancer, in the 50s, filters were added to cigarettes. In the 70s, the industry began to sell cigarettes that had a lower yield of tar and nicotine measured by machine. And then the idea of using smokeless tobacco. So some of these light, low tar products from the 70s had names like mild and light. And the Virginia Slims, you might notice, for the smokers of America who prefer low tar and nicotine cigarettes. Well, what it turned out is that this was misleading, because low tar and nicotine as measured by a machine did not mean less risk. And this was an important part of the lawsuit of our government against the tobacco industry, that they had misled people. So now the controversies are about electronic cigarettes and these heat not burn products, and whether they offer an advance, a way for people to get nicotine, but not to have all the risks that come with smoking cigarettes. So the story of the electronic cigarettes is still quite short. This is a Chinese chemist who patented the current electronic cigarette in 2003, so not even 20 years ago. And I was shown electronic cigarettes maybe 6 or 7 years after this patent, and I did not think they would be successful. I was wrong. And of course, since then, we've been through many different generations of electronic products. I mean, I'm actually not even showing you the very latest here. And some, as you know, have been incredibly successful, like Juul, which delivered nicotine in a way that smokers liked it, a very large hit, and in a way that made it very dangerous because it quickly addicted. And in the United States, we had an epidemic of nicotine addiction caused by Juul. These are small, and children would take them to school, use them, and they could use them secretly because they don't make a big vape cloud. They're designed not to make that kind of cloud. So a big problem. So one question is, can smokers use these for harm reduction? Will they help quit? Not so clear to me. And what are the risks? And then now these heat not burn products, IQOS being the first widely marketed by Philip Morris International, Altria in the United States. This is approved in the United States as a product that can be marketed as reducing exposure to dangerous chemicals. So those are sort of the harm reduction options. Now, here's my last slide about the concerns. So if we're going to do harm reduction, we want to make sure that the benefits, los beneficios, outweigh the harms, los daños. And so if we think about it, who benefits from electronic cigarettes in particular, or perhaps IQOS? Well, adult smokers do, because they reduce their disease if they switch to these, or if it helps people to quit. And people who have heart and lung disease who switch to these would benefit. Now, who is potentially harmed by electronic cigarettes? Well, adults who might have quit, but now continue to use nicotine and maybe switch back and forth between cigarettes and electronic cigarettes. Maybe people have quit, start using these and become addicted to nicotine and go back to cigarettes. They make being addicted to nicotine normal potentially. And there's some risk of secondhand exposure. But I think really important are children. And we've learned already that Juul addicted large numbers of children. These devices have been very, very popular. Children have had access to them. And we don't know if the 14-year-old who becomes addicted to Juul is going to be a smoker at age 20 and perhaps get lung cancer at age 40. So we really don't know. So how this balance comes out is really, really critical. And if you're a parent, you certainly are worrying about children, while perhaps if you're a 60-year-old smoker, you're worried about your own risks. But how these trade off is really, really important. And I think the answer is not in, and there's certainly a lot of controversy about the role of electronic cigarettes and to come IQOS in harm reduction. So, and then of course we have the problem of the acute lung disease from vaping, EVALI, which seems to have come and gone. So I'm going to stop here. Here's a few resources, articles I've written recently, and let's see, we'll make sure that you have access to these references, and I'll stop here and thank you for the opportunity to speak with you, and let's have a conversation. So thank you and gracias.
Muchísimas gracias, doctor Samet. Excelente resumen y exposición sobre el pasado, el presente y el futuro del cáncer de pulmón. Tal vez quisiera que Joaquín hiciera sus primeros comentarios antes de que entráramos a las preguntas.
¿Con nosotros todavía?
Que tenemos, no nos han mandado preguntas todavía, pero vamos a ver. Joaquín, por favor.
Sí, antes que nada, de nuevo, John, es un tema, es una enfermedad interesante que pareciera que tuvo fin y luego nos damos cuenta que no precisamente. Me llamó particularmente la atención lo que mencionó brevemente del cáncer entre los no fumadores, aún habiendo solucionado el problema del asbestos. Primero, si pudiera comentar un poquito más de esto, sobre todo para países como los nuestros. Y segundo, está interesante la balanza que John puso de los cigarros electrónicos y el harm reduction que le llaman, donde esa es el impacto en los niños y adolescentes es particularmente interesante y está por verse. Pero si a esa balanza que puso John, and John, I'm making the comments in Spanish
Right,
if you want me to go to.
está bien.
Oh, okay. Si en esa balanza ponemos un ambiente como el de México o como el de Guatemala, donde todavía no se ha solucionado el problema de tabaco, como se ha hecho en algunos estados en Estados Unidos, no puedo decir que el país entero, pero por ejemplo Uruguay, que es un país que ha avanzado muchísimo,
Sí,
Australia, que ha avanzado muchísimo. Para Guatemala o México, ¿cómo ponemos esa balanza donde sí hay un grupo donde se beneficiaría de harm reduction y otro que probablemente podría ser dañado? Entonces, esos dos aspectos, John, y de nuevo, thank you very much, outstanding, as usual.
Gracias. So, asbestos is an interesting story because asbestos does cause lung cancer, and I think the evidence is sufficient to say it causes lung cancer in smokers and never smokers. It, of course, causes mesothelioma, and we still have yet to see, I think in the United States, or about to see, the peak of mesothelioma from exposures long ago. So we have mesothelioma as an indication of past asbestos exposure. Very controversial in the past was whether there was some form of synergism between asbestos and smoking and causing lung cancer. We looked at that in the very big IARC, International Agency for Research on Cancer monograph 20 years ago, and the evidence was not clear, and I don't think it's become clearer. I think Joaquin's question about what is right in terms of electronic cigarettes for harm reduction is important. The situation differs across different countries. And for example, in countries where there's a very limited tobacco epidemic, for example, I've been doing work in Eastern Africa, Ethiopia, Uganda. Smoking is very uncommon. There is no need to have electronic cigarettes for harm reduction. They could only create a problem. I think in the United States, Australia, the United Kingdom, where there are large numbers of adults still smoking, if electronic cigarettes could be used under policies that protect children, then it might be sensible to allow them, not for free access so that children can get them, but with limited access. Then finally, there are countries that are in between in the status of the tobacco epidemic, Mexico, for example, or Guatemala. And I think in these countries, it would be important to very carefully be able to weigh the risks and benefits and the risks to children. I mean, right now in Mexico, my understanding is that electronic cigarettes are not legal. I was last there 2 years ago, just before the pandemic, and electronic cigarettes were sold in shopping centers in carts. So unrestricted access is dangerous. I'm actually part of a team. There are two teams, the US National Cancer Institute and Cancer Research UK have a very large Grand Challenge grant program with one of the programs being directed at electronic cigarettes. And I don't know if our team will be successful, but our goal is to develop what we call a tobacco scorecard that would be useful for making the decision about whether harm reduction approach with electronic cigarettes fits the national context. So that would be very much, I think, Joaquin, and sort of long answer to your very important question.
Thank you, John.
I have a question here. Jose Monzon, he's a student of Joaquin. He says, great presentation, very interesting. I really like the risk-benefit assessment for IQOS and such. Is there any additional data on flavors and additives that are included, particularly in electronic cigarettes?
Right.
In regards to this harm reduction, it would seem that harm is even more important given their appeal on use.
Right. Right. No, really important question. And I mean, one of the most important flavors worldwide, of course, is menthol. And menthol is the only flavor allowed now in cigarettes in the United States for a number of reasons. 10 years ago, I chaired the committee at FDA called the Tobacco Products Scientific Advisory Committee. And our first report was on menthol in cigarettes. And we concluded that having menthol in cigarettes damaged public health. 10 years later, FDA is finally beginning to consider banning of menthol. And some of our cities in the United States have banned menthol, and some states will likely do so. Menthol is it's a very good additive for the tobacco industry. It, of course, cools, it anesthetizes, and it makes the harsh smoke go down more easily. And it addresses nicotine as irritating. So it balances the irritation of nicotine. The flavorings is also important because they have been so attractive to youth. And cigarettes have been marketed to youth with many different names and flavors. We have some control on flavors now on cigarettes, electronic cigarettes sold in the conventional marketplace, but not in all of the different shops where they are sold. There is concern with two things with the flavors. One, they are attractive to youth. And second, some of them are probably dangerous. And one of the very well-known agents in some of the flavors early on was a chemical called diacetyl, which is a common flavoring. And it's the one, if you know the story, caused a potentially fatal lung disease in people who make popcorn, microwave popcorn, who were mixing this chemical. And they developed a disease of the small airways of the lung. And some people needed lung transplant or died. And that flavoring was in electronic cigarettes. I think it's 7 years ago now that my colleagues and I wrote an editorial in the Journal of the American Medical Association warning about flavors. And they're clearly, particularly because of the youth appeal, but who knows, inhaling flavorings that we don't know about the risks for 20 or 30 years may lead to lung damage for the long run, or perhaps other consequences. So great question, important one.
Thank you, doctor. Doctor, aquí en Guatemala pues no tenemos datos muy confiables, pero sí sabemos que no es un gran problema el cáncer de pulmón, pero la percepción de no solo mía, sino de muchos otros es de que estamos viendo un buen número de casos de mujeres jóvenes. No sé si es una tendencia que se ha visto en otros países. No sé, obviamente aquí mucha gente en el área rural se cocina con leña.
Sí.
Cocina con leña. Y pues creemos de que por ahí puede estar el problema. Pero no sé si es una tendencia que se ha visto en algunos otros países o nada más es nuestra percepción, pero sí estamos viendo cierta cantidad de, mayor que antes, diríamos, en los últimos 20 años, de mujeres jóvenes
Sí, sí,
con
sí,
adenocarcinomas, ¿verdad?
sí, sí. No, entiendo. En inglés, un momento. So the problem of, what people call household air pollution, the indoor smoke from cooking and heating is now well studied. There was actually a very important trial in Guatemala of having a lower emission cook stove looking at respiratory infection in newborns, probably finished 10 or 15 years ago. There are carcinogens in that mixture. The global burden of disease has estimates on, how much lung cancer might be caused by this kind of exposure worldwide, because there's still perhaps 2 billion people exposed to this kind of smoke from, burning many different things, biomass, wood, animal waste, coal. Around the world, there's a lot of exposure. I don't hear about cases in younger women, or I haven't, from colleagues. I understand that since exposure would begin at birth, it could well be that cases might occur in younger women who have been exposed for a long time, but I'm just not aware of reports in the literature that would provide good documentation. I know that I spent many years of my career in the state of New Mexico and saw many patients from Mexico. And some of the women I saw did have obstructive lung disease who had never smoked. And it seemed to be their exposure to this indoor smoke that was responsible. I mean, many of them had been exposed to very high levels, and in fact had very pigmented lungs from their years of exposure. But lung cancer, I'm sure this kind of exposure causes lung cancer. I just don't know much about the age distribution around the world.
Joaquín, ¿quieres agregar algo? No sé si estás ahí todavía.
Aquí estoy. Pues no, yo creo que sería cuestión de que si alguien más de los asistentes tiene alguna pregunta o comentario, de nuevo, como vos dijiste, Cedi, este sí es un broche de oro para los seminarios de íntegra. Y sí creo que queda claro que es una enfermedad que, al igual que el coronavirus, parecía que ya tenía luz al final del túnel, pero que todavía sigue siendo un problema. Dos mensajes para ver a futuro en Guatemala, creo yo, aparte del control de tabaco, es muy importante lo que dijo John del tamizaje y el acceso a tratamientos, aunque también hay que ver la sobrevida, la gráfica de sobrevida que mencionó solamente.
Yo tengo una pregunta tal vez muy básica y hasta tonta tal vez, pero ¿cuál es la definición de un fumador? Y si eso es algo ya estandarizado.
Bueno. Había muchas discusiones. Usualmente, como un fumador ha usado 100 cigarrillos en la vida. 100.
En la vida.
En la vida, sí. Más o menos, 100, sí. Y probablemente un fumador necesita fumar como tal vez 100 o más cigarrillos para devenir adictivo. Sí. Uh-huh. Usualmente usamos 100 cigarrillos.
Okay.
Sí.
no durante un span de tiempo, sino en
No,
general
no,
durante la
en
vida.
total, sí.
Ya, ok. Bueno, pues no veo más preguntas. No sé si alguien... aquí está el doctor
Miguel.
Garcés pidiendo la mano. Ahorita vamos a darle...
Voy a hablar, doctor.
Por favor. Doctor Garcés.
Gracias, Eddie. I have a question. When you compare the histological type of cancer between smokers and non-smokers, is the difference same
Yes.
in both groups? I mean, are you having more adenocarcinomas also in non-smokers or only in smokers? Or how does that behave?
Right. So most cancers in non-smokers, 70, 80% have been adenocarcinomas going back decades.
Okay.
It would be very rare, for example, to see a small cell cancer in a non-smoker. I think what is particularly interesting, and I showed you that one paper in Science from the UK from Mike Stratton, is the differing spectrum of mutations. They're quite different in the cancers of those who have never smoked and those who smoke. So I think, beyond the histology, these genetic differences are really, really important. And, given there are so many different carcinogens and irritants in tobacco smoke, it's perhaps not surprising that you see far more mutations in lung cancers in smokers than in never smokers. But I hope we get some good clues to what are the mechanisms. There's probably in smokers many paths of mutagenesis to having a cancer. I mean, if it's, however many, a multi-step model, we think 4 or 5 different mutations to get to a malignancy. There are probably many different paths in smokers. And I think we'll learn a lot more over the years to come. And maybe ways that will help us, then with single cell analysis for screening for potential lung cancers.
Thank you, doctor. Okay, thanks.
¿Hay alguna evidencia de que, porque ahora hay mucha biopsia líquida para el seguimiento de muchos cánceres de pulmón, pero tal vez esas biopsias líquidas o muestras líquidas pudieran, como dice usted, servir como screening más adelante?
I would think so. I would hope so. I mean, I think we're not, as you know, we're not there yet, but the possibilities are there. And I'm sure that in the future, we will probably be having, liquid biopsies, single cell analyses for, different cancers. I mean, I think that's going to be very promising.
Okay. Muy bien. Pues no veo más preguntas ni comentarios. No más nos queda agradecerles a Joaquín y sobre todo al doctor Samet que nos ha acompañado en nuestro último webinar. Ha sido un verdadero honor que nos haya acompañado
Gracias.
en nuestras actividades docentes, y esto es la última y creo que cerramos, como dije al principio, con broche de oro. Así que muchísimas gracias, doctor Samet.
Sí.
Ojalá muy pronto lo podamos tener en Guatemala.
Espero que sí. Bueno, gracias. Buenas noches a todos. Ha llegado a Joaquín, parece.
Ya estamos en Pantaleón, John. Estamos haciendo investigación en contaminación del aire, los trabajadores de caña, con el equipo de John de la Universidad de Colorado aquí en Escuintla, y es parte del equipo de John. So queda que ya estamos aquí sanos y salvos, John.
Bueno, diga hola a todos.
I will.
Bueno, hasta luego entonces.
Gracias a todos.
Muchas gracias.
Thank you very much again, John.
Gracias, doctor.
Sí.
Nos vemos.
Adiós.
Y buenas noches a todos, muchas gracias. Nos vemos el año próximo. Que todos tengan una feliz Navidad, un feliz año y nos vemos el próximo año. Y cuídense del COVID, por favor. Nos vemos.